I'm here today to talk with you about bullying. This is probably a really common topic you see with your patients that are coming in. We're going to learn a little bit today about the state of the research, what we know about bullying, what kinds of effects it has on our youth population, and then we're going to talk a little bit about what you can do in your role with your patients in terms of prevention, screening, and treatment. So we're just going to dive right in here, and hopefully you learn something. All right, so there used to be not a lot of clarification in terms of what bullying is and a unified definition. After Columbine in 1999, there was a lot of more attention and focus around bullying and trying to operationally define it so that we can do a lot more research and really understand this problem to be able to help our youth and maybe work towards reducing bullying. Unfortunately, we haven't seen that there's been a big reduction in bullying since we first started researching it and collecting data. But there are a lot more programs out there now and a lot more awareness. And we're going to talk a little bit in later slides what that looks like. But in 2016, the CDC really clarified a definition for bullying that we use, and that's most common in the research. So we have three key elements here, three ingredients. First of all, this is behavior that is repetitive. So it's not just a one-time off occurrence. That doesn't mean that a one-time off occurrence can't be hurtful or damaging, but it's not really meeting that criteria of bullying. So what we're looking for here is a longitudinal type of behavior that's occurring over time, and that with the next one, there's a power imbalance. So that can be not only a true power imbalance, such as different sizes of kids, so if there's a child who's bigger than another, kids who are older than another, but it could also be a perceived power imbalance. So that could be things like that one child seems to have more resources or social status or some kind of power over the other child in some way. So that it's more of like a perceived power imbalance, not necessarily just kind of the obvious things that we know and can see. So even kids who are the same age, who are even friends, it still could potentially meet criteria for bullying depending on if there's that perceived power imbalance. And then lastly, intentionality. So this is not behaviors that were a miscommunication or interpreted, one kid interpreted it differently from the other, but this is really about like choosing to be hurtful, choosing to be mean-spirited, and that's where we get our definition here of bullying. So I just wanted to point out here, and I'm going to do my best today in this presentation to remember this and be mindful around how we talk about bullying. So I encourage everybody to really focus on the behavior and not labeling kids, because when we label the kid, it doesn't take into account the various factors that go into bullying relationships, including the environment, the dynamics at play, the fact that sometimes kids can be on both sides of this, so they can be getting bullied, but they could also themselves act as a bully themselves. So because of all of that and the fact that we want to encourage and elicit change, we don't want to label the child as a bully or a victim, but instead focusing on the behavior. So I've been practicing and making sure that I've been more mindful of this, and I encourage you to all do the same. So what does it look like out there? What's the landscape? As you can see here on this chart, the peak prevalence for bullying is in about 6th grade. So that's where the majority of this kind of behavior is happening. But what I'd also point out is these are things that we can hear even as young as preschool. And so some of these dynamics start very, very young. And by kindergarten, about 14% of kids are they're getting bullied at that time. And then it raises in about 6th grade to, I think, about 30%, and then tapering off in high school to about like 20 to 25%. Unfortunately, if you look at the research, the rates of bullying are really, really variable depending on how the data was collected, what kind of surveys they used. Was it a random sample of kids where a researcher came in and queried them, or was it a school-based survey that everybody gets? So the rates really vary. In one meta-analysis from about 80 studies, the rates for bullying were anywhere between 35 to 50%. In other studies, they found rates of as much as 50%. So it really varies across where you're looking at the data and how they're collecting it, and what they're defining as bullying, although now it's getting a little better because we do have a more unified definition. So I would say we're on solid ground to say, anywhere between 20 to 30% of kids are affected. So when we talk about bullying, I know a lot of you are probably wondering about cyberbullying, and we'll get to that in a minute. But anything other than cyberbullying, we generally call traditional bullying. So here you'll see are the three main types of traditional bullying, including verbal, physical, and relational aggression. If you're not as familiar with relational aggression, sometimes you might have heard the word like psychological bullying, so that's going to fall under the same category. In psychological research, we often use the word relational aggression, so that's the preferred term. But it's essentially those same behaviors that you see here, and tend to be a little bit more from like a developmental perspective. Like little kids might not be able to engage in these behaviors as much because you really need to have that like level of social savvy that kindergartners or early elementary schoolers are not going to have as much of. And we'll see here in a minute a graph of how that plays out. But these are the three main types, and there's not necessarily one that's worse or less impacted than another. It really just depends on the circumstances. So this chart, I think one of the things I would point out to you here is how we were talking about earlier, the rates of bullying can really vary depending on what study we're looking at. So you can just even see on this chart, the rates that they're reporting in this study are quite higher than a lot of the other things I've seen. But some trends I'd point out here is, as you can see, this study included verbal bullying into their definition of relational aggression. So those rates are quite high. So that seems to be, in their research, the most common form of bullying that is being reported among all age groups. When you look at physical intimidation there, what you'll notice is that's really happening more in the younger age groups and really tapering off towards high school students. So little kids, their brains are less developed, so they're like oftentimes acting out more physically. So that's why we see that pattern. And then as kids get older, they're using more of these like high-level strategies. And then we'll talk a little bit about why this looks like the way it does in a second. So cyberbullying is quite a hot topic, and I wanted to spend a little bit of time touching on that today because I think just having good information about how this is impacting kids and what it really looks like is good for you to know about. So cyberbullying, we're going to talk about some different types of cyberbullying, but I think in general terms, this is bullying that's occurring through the internet of some kind, whether it be social media or text messaging or in different chat groups and things like that. So all of that is going to fall under the definition of cyberbullying. What we know is that cyberbullying rarely occurs in isolation. So some people ask, like, why are the rates of cyberbullying so much lower than traditional bullying? And it's really because if you're being cyberbullied, more often than not, you're being bullied in the traditional ways too. So it's not something that's occurring in isolation, and like 90 to 95% of kids who are being cyberbullied are also getting bullied at school. So it's not something that's like unique or happening separately off, like on the side from the traditional bullying. It's something that's usually co-occurring. There's some things that potentially have the ability to make cyberbullying somewhat more damaging in a lot of cases. So as you can imagine, it's really pervasive and persistent. When kids leave school, they can't just like leave all of that stress behind and come home and have like a safe space. But oftentimes these things are following them home. They can't escape it. It's all over the internet. So it can really have this way of being insidious in their lives. And then also, it's occurring 24/7. So these things can be happening at all times of the day or night. It's constant. Kids feel really bombarded and out of control. Once it's up on the internet, we know like it has the potential to be there forever, and that it can be viewed many times by a really wide audience. So if you can imagine, in a traditional bullying scenario, there might be one child who's doing the bullying or a group of children, another child who's getting bullied, and then maybe a handful of bystanders around. So maybe like 10 kids are involved in this scenario. But when we come to cyberbullying, This has the potential of reaching everybody at school or even above and beyond just that one school. So it really has a way of impacting kids, more broadly because so many kids are seeing this, sharing it, aware of it, and it can really be potentially really damaging, and just the ability for that to spread really rapidly as well. So those are some things specifically about cyberbullying. Another thing I would add here is that when somebody, especially teenagers who are still, their brains are still developing, when they are behind this curtain of anonymity and they feel like maybe they have that shield, what they might say that was mean in person can be 10 times more mean or more aggressive or more hurtful when they're not right in front of that person. They might be somewhat emboldened. So even if they were going to be bullying, in person anyway, it could potentially be more severe online. And then also because they're not seeing the reaction of the other child, there's not that feedback cycle of seeing, like, I say this thing, I've really hurt that person, I can see by the look on their face and how they're responding, and maybe having that be a moment to change course or have a learning experience there. Since they don't see that reaction, it tends to then maybe make it so that person will continue to do it because they don't really get that feedback of, oh, maybe this is not appropriate. So some kind of specific things there. Cyberbullying does peak a little bit later, I think it's 9th grade. So as you can imagine, high schoolers are going to have more access to technology. It's going to be less monitored by adults. So that is probably why we're seeing more of that in our older populations. This is just a little chart here of some things you might hear from your patients around different types of cyberbullying. Certainly some of these, like sexting and cyberstalking, might, depending on what exactly is going on, has the potential to reach a higher level of acuity. Like in Washington State, we have certain laws around harassment and sexting. So, potentially these have more legal implications. But some of them are going to be more classic bullying, but it really spans the spectrum. And there's a lot of different ways that kids can be bullied online, as you can see here. So just a quick note about this slide. I made it very pretty, which I like, but I love all the colors. The arrow here doesn't really mean anything. It's just showing that there's a spectrum here of behaviors, but it's not in any particular order, so I just want to highlight that. But this is just a list of things, because I think a lot of people are like, well, what's the difference between bullying and harassment? What's the difference between being a mean girl or being mean and actual bullying? And it's actually not always very clear, and I would say that it's not necessarily your job to be a detective and to determine well, is this bullying or is this something else? I think it's good to know what bullying is, but some of these nuances are really particular, so I wouldn't worry too much about it. I did put on here just some ways that you might be able to see some of the differences play out. So clearly meanness is not good. It is intentional, so it meets that criteria. Remember the 3 ingredients. So it has some of the ingredients, but the one it's missing is that it's not persistent over time. So it doesn't have that longitudinal kind of flavor to it. Teasing, similar, has some of the ingredients. Could happen over time, could potentially have a power imbalance, but the intention isn't quite there in all cases. So in a lot of teasing, it might be between friends and it's in jest, or one child doesn't intend it to be mean. And so it's not quite fully bullying, although I think it's definitely a fine line there in a lot of circumstances. And then we have these other categories, some of which are have a higher level of acuity than bullying itself and reach kind of within our legal system, have their own definitions and their own responses. So there's definitely a lot of overlap here. Like if you imagine a Venn diagram, you'd see a lot of the overlap, but there are some slight differences here just to be aware. What I would say about this is that this is a pretty big list of risk factors. I think one thing that stands out to me is just ACEs. So a number of factors on here, adverse childhood experiences, we see a lot of that coming up, but it's also a really comprehensive list. So I would argue that, a lot of your kids that you're working with probably maybe fall under one of these categories, and that bullying can really impact anyone. And so you certainly don't have to have these risk factors, but the research does tell us that kids who are more at risk are having some of these types of situations in their background. And so just to be aware of that as you're thinking about screening and maybe kids that might be at higher risk, these are some things to be thinking about. We used to have this belief that kids who already had a bunch of problems were getting targeted, so they were getting bullied, and the bullying itself wasn't actually causing any damage. It was like all the other stuff going on in their life. But now we know, and we've made a really good case, that the actual getting bullied is leading to adjustment problems, not only in the short term, so like as the child is in school and the effects it's having on them in that environment, but also long term that follows them potentially all the way into adulthood. So I think that is, the key reason I'm up here today is to share with you that as you're working with your patients, this is a really big factor that's going to maybe set them on a certain trajectory in their lives if it doesn't get addressed appropriately. So I definitely think it's important to be considering how the short-term impacts of this might carry on into their adult lives and how that might look from a population-based health perspective. These are some outcomes that we know about as far as like what bullying might lead to. The list includes both short-term and long-term consequences. So everything from somatic complaints, aches, pains, headaches, stomach aches, you probably hear that a lot, insomnia, disengagement from school, school avoidance problems, depression, anxiety, and also sometimes for kids, if they're managing a chronic condition, you might see that previously they were managing quite well and they were very compliant, and all of a sudden you might notice a big change in their compliance. And so that's another red flag that might not necessarily make the connection of like a youth who has asthma, who was previously doing quite well with their treatment, is now having more struggles. There's a potential that they might be having problems with bullying, and to just consider that. So I have done some of my own research on this topic, and I just wanted to share with you a little bit, without going too deep in the weeds with this, that correlates to some of the conversation we're having currently. So I looked at public and private high schools in our area and talked to kids about their bullying experiences and their psychological adjustment, so primarily looking at depression and anxiety. And as you can see here, I don't know how hard it is to read this graph, but bullying was broken out into no victimization, low, moderate, and high. And blue is private school, green is public school. So what you see is this trend that we just talked about. So as bullying increases over time, as bullying increases in severity and number of experiences, psychological adjustment problems also increase. So this is just like a zoomed in local example of what we've been talking about in that relationship there. And I can't quite remember, I was looking at this last night, I can't quite remember why with this private school for the low category here, it drops down. I think I probably had some theories about that at the time, but it's been a number of years now, So what are some signs and symptoms? This connects back to outcomes that you might see. Sudden noncompliance and poor management of health conditions, school avoidance, somatic complaints, increase of substance or starting substance use, suicidal ideation, depression, and anxiety. Probably things you have awareness about that you might see. And then we're going to shift gears a little bit to talk about the other side of things, getting bullied. So there's not as much research on kids who are doing the bullying compared to those who are getting bullied. So we don't have quite as much information about that, but we do have these, it's kind of an interesting dichotomy. We have these two types of kids that we know tend to be involved in bullying, and they look very different. So on one hand, we have these well-connected, socially savvy, kind of high-power kids who might appear on the surface as like really high-functioning. They have a lot of friends. They're really well-connected. And then on the opposite side of the spectrum, we have kids who are more isolated. They're disengaged. They have poor self-esteem. They might have lower ability to empathize, or they don't have empathy skills. And so these kids can look really different. So sometimes it's hard to identify, like, oh, this kid is, more at risk for being a bully because of these characteristics. It might not be that straightforward because it can look really different. But we do know that there's a number of risk factors as well, and certainly family trauma in the background, permissive parenting styles, just general behavioral problems and otherwise. Oh, and that, I don't know if you guys remember, there was a movie, I think it was released in 2011, called Bullied, and pretty good film there if you're interested. So the thing that I think is really interesting about this list, in contrast to the one that we looked at about risk factors for getting bullied, is the overlap. So everything here with an asterisk are things that are also put for risk factors for kids who are getting bullied. So the vast majority of these outcomes are applicable to both getting bullied and being a perpetrator of bullying. So I think that's something we don't always think about. We think about maybe in a victim role that you might have more negative outcomes, but actually for those who are doing the bullying, they tend to have a lot of negative outcomes that are very similar and track along a parallel with those who are getting bullied. So a lot of these things are really similar. One category of kids we haven't talked about, so we've talked about getting, yes, mean girls. We've talked about getting bullied, we've talked about doing the bullying, but what we haven't talked about is kids who are in both categories. So kids who are in both categories are going to have similar profiles in terms of risk, in terms of outcomes, but they tend to have the worst outcomes and tend to be the most affected. So these are the kids who you might see that have some of these more like higher level issues around self-esteem, peer rejection, a lot of like high drama, high stress around their social circles and their peer relationships. On one hand, they're, trying to maintain their whatever social power they have. So if they're, in potentially a popular group, but on the other hand, those same kids who they're trying to cling to are also, doing some of these bullying behaviors. So they have a lot of high distress and a lot of problems in like their relationships and how they view relationships and maintain those relationships. So these are the kids who are having the most problems. We're going to have a great talk in a little bit on youth and suicide, so I'm not going to get too into the weeds here, but what I want to highlight is that one of those outcomes we talked about earlier for both getting bullied and being a bully is that it puts kids at an increased risk for suicidal ideation. So what we know about that is there's certain groups that are more impacted than others. So girls being at higher risk than boys, LGBTQIA, and kids who have learning disabilities are going to be at a higher risk. And then kind of the highest risk group, again, are those bully victim kids who are getting both of that on both sides. So certain groups are more impacted than others, but we do know there is a link here. What I would also keep in mind, though, is that it only really accounts for some of the variability within suicidal ideation. There's a lot of complex factors at play when we talk about that issue. And so while bullying is like one variable in here, it's definitely not accounting for a large share of suicidal ideation. Protective factors. Okay. So when we get to talking about screening here in a little bit, we can talk about this more, but as far as like promotion of these protective factors, these are a lot of things that you can consider because you can be talking to your patients even before these experiences come up to really help buffer them against the potential for being bullied. And it's something that you can discuss as part of your well visits and just kind of boosting their competence in relationships. So bystanders, we're going to talk a little bit about what a good bystander looks like here in a minute. But what I want to share with you is that the research really tells us that how the bystanders act in a situation of bullying has a huge impact on not only the immediate outcome of that situation around them, but can set like a culture in a school of kind of that this behavior isn't okay and that we don't accept it here. So if every single time those bullying incidents are getting shut down by bystanders, eventually it's going to really shift a culture of a school. So I think it's really important that it's not just an immediate stopgap, but it has like long-term implications for that culture and that environment. And then also it has impact on the patient's well-being. So we know that when there is better bystander intervention, that the self-esteem of the child who's getting bullied and their feelings of acceptance are boosted up. So it has a lot of really great things about it, and that's why we often focus on the bystander role. One thing to think about in your role is the power of labeling this as bullying. So even if this comes up in the last minute of your visit and you're just so overwhelmed and thinking like, oh man, I don't have time to assess, I don't have time to kind of get into all of these things, but if what you're hearing sounds to you like bullying, if the one thing you do is say, that sounds like bullying, and we can talk about a few more talking points you can say, but like just by labeling it, we know that there's a huge impact on kids, whether or not they go on to report it further and seek help for it, and how they might be responding to that. So just by labeling it has a big impact on kids, so I definitely encourage you to be doing that with your patients. Having a really wide peer group can be a protective factor, so not just having one small group of friends, but really having the ability to befriend kids in other groups as well. Good peer and parenting relationships, a culture that prioritizes diversity in schools, and then high rates of resilience. So in my research, I've looked at resilience in a few different areas, so both internal, so your internal cognitive factors like sense of mastery, for example, but also external resilience, which includes things like being connected to school, having some kind of an activity that you do, how you feel like your relationships are with the teachers and the staff at your school. So resilience can be something that can certainly be taught or encouraged depending on the child's situation. So we're going to shift gears here and talk a little bit about things that you can be doing. You've probably just extrapolated some ideas from things that we've already talked about, but I want to get a little bit more intentional around what you can be doing in your visits. So from a prevention standpoint, we talked about the role of labeling and how that's important. I think early on with kids, even before you're hearing about these bullying incidents, just being able to encourage parents to talk about what's happening at school and have that be a regular practice is really great. And my guess is the vast majority of you are already doing this in your visits anyway. So just knowing that that has a protective impact on kids. Having some good guidelines for parental monitoring, I think, is really great. So having those conversations about different resources that parents can use and different rules they can set up. I think Common Sense Media has a really great little outline for parents that can help them guide how they might set up some of these boundaries around their internet use and things like that. Reducing stigma and normalizing and validating the impact. So if you're educating your patients about bullying, talking about that it's serious, talking about what to do, if they're seeing these behaviors, then perhaps in the future, if it comes up, they're going to be more willing to disclose and talk about it and make a plan around it. So I think having those conversations with all kids is just a great way to normalize it and just reduce that stigma. Upstanding. So upstanding is a fancy word for being a good bystander. So we talked about the role of bystanders earlier, and that's definitely an educational piece that you can do, is talk about how kids might be an upstander if they're seeing behaviors at school that are inappropriate or mean or whatnot. So as far as some of the language you can use around upstanding, talking about things that kids can do. So if you see somebody getting bullied, what do you think would be a good thing to do? And you can have them brainstorm and share things like, ask them to walk away with you, go find an adult, tell the bully, stop that right now, question the bully, how do you know that's true? So there's some language you can use and have the child brainstorm some ideas as well. It's something you could spend even 15, 20 seconds on. It can be really fast. In your resource packet that I put together for you, I have a nice little handout on upstanding. So you could just share with kids, I think it's really important that you feel like you can stand up for your classmates. If you see bullying happening, it's great to be an upstander. Here's some ideas for you to do that. And it can be as simple as that. So the role of upstanding, again, is so important in this. Encourage connection to school and self-esteem building activities. So if kids are not really connected to school, we know that puts them at higher risk. So you can definitely help with the parent there, maybe identify a club that they could join or a group, whether it be out of school, in school or outside of school. Our kindergartners are around age 6 when they start, and that's the age at which the American Academy of Pediatrics recommends starting screening. So there isn't really an evidence-based screening tool that we use in primary care, and I don't know like how you all are feeling about like knowing what questions to ask or what might be helpful. Certainly a lot of the questions you're already asking are going to touch on some of these things because you're going to be asking about, what do you think about school? What do you like? So some of it is going to get you a toehold in some of these areas, but there's certainly some more specific questions that you can ask. Again, in that resource packet, I put a list of the questions I like to ask. So you could certainly copy and paste that, create a dot phrase, plop it in your note, and you could just have that as like a template for you to kind of navigate through. And it's really not that much. So some of the things I like to ask are, what do you think about school? So not necessarily suggesting they like it or not, but just say like, tell me about your school. And that alone can elicit like a general vibe, Sometimes I'll see kids just like go like this. I'm like, okay, this is something we need to talk about. Certainly asking about things that they like and don't like. I often will ask, are any kids bothering you? So not really putting a lot of that labeling of bullying on, but just asking, are kids bothering you? Are kids being mean to you? That should help elicit some of additional responding. I would encourage you to avoid the term bullying. So not saying, is anyone bullying you? Because one of two things might happen. One is that maybe they don't really know what bullying is, so they might just say no, but maybe they are getting bullied, but they have some idea in their mind of what that means. And so, they've just already decided and made up their mind. Or on the other side of things, they hear that term and they don't really want to disclose and they know that you're questioning them and they kind of clam up and they don't want to talk about it, so they just shut down. So in your assessment, I recommend that you don't actually use the word bullying, but instead ask questions like, is anybody bothering you? Are you seeing other kids being bothered? Is there anything at school that makes you uncomfortable or feel unsafe? So some of those more general questions. And then if it's clear to you and you're questioning that there is bullying happening, then of course, label, it sounds like you're being bullied, and go from there. If you are hearing comments that sound like they could be bullying, trying to get a little bit more detail around like, how long has this been going on to get our happening over time? Where is it occurring? Who is involved? Has it already been reported? I know a lot of times when I talk with kids about this, I hear about incidences, but then it turns out like the parent's already aware and the school's already aware. So not always necessarily something to be done except to reinforce the efforts, but just making sure we know where we're at with all of it. And then because of what we talked about before in terms of outcomes, make sure you're screening for other mental health issues and risk factors. So treatment, there is a lot that you can do. And I think sometimes, I know I felt this way in the past, because it feels a little bit removed, like this is something that's happening at school with other adults involved, and it feels very like away from our clinics. Sometimes it can feel a little bit like, well, what can I do about this problem? Like, I don't work at the school. I don't really know how things are there. But in fact, there's a lot that we can do. And we talked just about the power before of like, just saying that sounds like bullying and the importance of calling it out. Some other things to think about are identifying a supportive network around the child, so helping them identify a safe parent at school, a place that they can go where they feel safe when this is occurring, and just helping them have that kind of visual sense of where they can go and who they can talk to when these things are coming up. Education, after you label it as bullying, these are some key points to convey. So it's not their fault. Nobody deserves to be treated this way. You should be able to feel safe in school. And I think this is the most important one. It's the adult's responsibility to make it stop. Okay? And I'm going to talk about that a little bit more on the next slide. So in the past, I definitely know I'm guilty of this. In the spirit of wanting to jump in and offer something to the child, I think there's a lot of discussion around like, well, have you tried walking away? Have you told them to stop? Like giving them some of that advice. And so what we know from the more recent research is it's not that those suggestions are wrong or bad. Like certainly if someone's bullying you, probably ignoring them is a good thing to do. But the problem with offering that as your advice is that most of the time kids have already tried that and it doesn't work. It kind of sends a message that it's on them to do something, and there's like attention being taken off like the complex dynamics at play when these behaviors are occurring, and it kind of takes the power away from the child because it's just kind of telling them what to do. And we also know that kids find it really kind of dispiriting when they get that advice. So in surveys of youth, we found that when they hear that, it just makes them kind of shut down and not want to do anything, and kind of tends to worsen the problem. So I'd encourage you all to move away from that. And I know it just feels sometimes like an easy thing to do, or you want to kind of offer them something. Just know that it's not particularly helpful, so we don't need to put as much focus around that. But there's a lot of other things you can do. So we talked about needing to get adults involved, and that being one of the most important things. So being able to link to the school bullying policy is going to be really key when you're talking with parents. In your packet, I have a ton of stuff, a ton of handouts about bullying policy in Washington State. If any school that receives state funding is required by law to have a bullying policy, and as part of that bullying policy, they're going to have information about what bullying is, the point person who at that particular school is responsible for like handling these complaints, and then what the action plan is. And that should be on most school websites. So parents should have easy access to this. And I'm often really surprised how few parents are aware of it. And a lot of the times parents don't even know that it's a thing, that they have a clear, protocol in place to help with this problem. So being able to educate parents and tell them, did you know that there's a bullying policy? Here's how you can access it. Just really encouraging them around that, I think, is good. And then if the child is really not wanting to disclose, so if they've told you about it, but maybe they don't feel ready to tell their school, or they don't want to involve their school, or they're not even sharing it with their parent yet, you can use some motivational interviewing to help encourage that disclosure. So moving away from kind of giving these old school advice around like just walk away, ignore them, what can you do instead? What you can do is take this approach here. And I have, I'll show you on the next slide, I have a little example of an action plan. But in your resource library, I have a link to a blank plan that you could either print for the patient to do with their parent. You could just use it as a template for talking points. You could even look at it with the child. Or you could just ask the questions. And so what that looks like is once you've got all the information about what occurred, you're going to be asking what the patient would like to be done about it. So that's all you have to say. Well, what would you like done? How would you like this to be handled? And have them tell you. And then once you have that information, brainstorm what steps are needed to enact that plan. So this is all about like empowering the child and putting the ball in their court and using their own language to help them feel confident that we're going to all work together and the adults are going to step in and hear your voice and make a plan together. So those are the 3 steps that you can do in terms of problem solving the bullying that's occurring. Some other things to think about, because we know, as we talked about before, all of the various outcomes we know that might affect kids are some of these things. So identifying strengths and self-esteem building activities. If you already know this child and you know like they're on the school basketball team or they're in the robotics club, like maybe it's just around reinforcing that like, I think it's great that you're engaged with your school, and I think it's important that you continue doing that because it's really good for your mental health and your self-esteem. So it could just be, letting them know that you encourage that. If they're really disengaged and shut down, you might need to have a little bit more time to like identify something that does make them feel good or that they would be willing to do, whether it be a hobby at home or finding something in the community with another peer group that like the kids at school don't know can be really helpful. So like signing up for a local pottery class or something like that. And then also just doing some self-care. So I like to talk with patients about like when this is occurring, if you can, when you come home from school, if you can have some kind of a ritual that you do between school and home that indicates to yourself like, I'm setting this down for the day. So it could be anything from doing a breathing exercise to having a cup of hot chocolate to talking with a parent after school. So it could be a number of things, but just having some kind of a ritual that helps kids feel like they have some coping tools available to them. I did include in my packet just a few self-esteem building handouts that you can offer to families, and you can even look at with the patient if you have some time. And then some self-care planning materials as well. So these are all things you can offer patients even if you don't have time to like dig into them. Monitor and treat comorbid symptoms, and then if appropriate, you can refer to mental health treatment. So I just wanted to show you a quick example of like the plan that we were talking about. So this is one example. Step 1 is just really your assessment here. And then step 2 and 3 are those ones around like what does the child want done, and then what steps are needed to be able to enact that plan. I think the one hang up might be if the kid says something like, well, I want to go up and punch them in the face. You definitely want to like validate that they're very upset and that they want to take action, but also maybe some like problem solving around like, I hear that you're really frustrated and you just want it to stop, and that also doesn't sound like it's probably going to have a good outcome for you. You might just get in trouble. So help guiding them if you're hearing some of these things that aren't going to be really workable, and brainstorming some other solutions. I think that could potentially come up as well. So just having that in your awareness. So that brings me to the end of my talk. I have no idea how long I've been talking or what time it is, but hopefully I've stayed on time. And I'll be available to answer questions in a little bit.